Hi, my name is David Schuster. I am the Director of Nuclear Medicine and Molecular Imaging at Emory University in Atlanta. So to address the concept of false negatives, we have to understand that most clinical PET for lymphoma or myeloma uses a radiotracer called FDG, or fluorodeoxyglucose. While an oversimplification, think of this radiotracer like a radioactive sugar substitute. As with any imaging, there are a number of causes of false negatives as well as false positives that an imager must be familiar with to provide accurate PET interpretation. It is helpful to divide the causes into broad categories. Let's call them tumor, technique, and preparation. First, let's discuss tumor. Certain lower grade or indolent neoplasia, by their nature, are not aggressive in their use of glucose. Gastric malt is a classic example of this, while extragastric malt is more FDG avid. SLL and CLL may have lower avidity, but if transformed to diffuse large B-cell lymphoma, have much higher FDG avidity. And we use this to our advantage when looking for this transformation. Interestingly, in the past, follicular lymphoma was believed to not be very FDG avid, but most are now shown to be avid enough on PET. Now, a subset of this category would be microscopic or small volume disease. Any imaging technique would be challenged compared with histology finding microscopic cells. I am sometimes asked what size lesion is the threshold for PET, but there is no way to answer that without knowing the inherent avidity of the tumor itself. So for example, a very avid lesion like Burkitt lymphoma, one can even see millimeter implants. For lesions that are not avid at all, you may easily see them on CT, but not PET. Also, if a lesion is necrotic, FDG may not get into the tumor sufficiently to light up on PET. Next is technique. If the radiotracer extravasate and does not get into the circulation, one will not get a good scan. Most of the time, this is pretty obvious on the images by assessing overall biodistribution. We check blood sugar levels since if they are too high, the body produces insulin, and this will drive the FDG into muscle away from tumor. The quality of the scanner is also important. If a patient gets scanned on a newer generation PET versus an older one, we often see smaller FDG avid lesions with lower levels of uptake. Finally, preparation. Because of the interference with insulin, it is important that the patient is fasting for at least 4 to 6 hours. Steroids can interfere with uptake of the FDG. Also, colony stimulating factor will drive the FDG into marrow and away from tumor, and one should wait at least 2 to 3 weeks between GCSF and PET. Recent chemotherapies, such as within 10 days, can also stun the cancer cells into not taking up FDG.